Loud enough? We're okay? Okay. Okay, so this is a perfect setup after Dr. Helm talked. If you think of things as a funnel, so he's talking about everybody, okay? But as you funnel down into your specialty, or even not in a specialty, so you're going to be an internist, or you're going to be in peds, period. There's no way to avoid the fact that you're going to have individuals who don't have intact communication skills, okay? And that's one of the largest barriers to accessing medical care, okay, and therapeutic care. And so if you want any of this, everything I'm telling you, there's evidence-based, and I have to tell you why. Pat, if you know Pat Kipsman, he came in my office, months ago, and he does this months ahead of time. So you're thinking, I have lots of time, right? And he comes in and he sits down, and he's so chatty and sweet. And essentially, he said, I want you to tell people about every communication disorder that exists and what you can do with it and all the technology that goes with it. Okay, Pat, I can do that. So what I did,
In 1 hour.
In 1 hour. Yeah, and so what I did was I flooded him with all these handouts, evidence-based, this and that, blah, blah, blah. And so he's got all those on his little website, and you can get them, okay? And so that was his payback. Okay, Pat, you want to know everything? I'm going to give you everything I can find. So anything that I say you can get the printouts, you can get the evidence, the research, whatever. He's got it. Okay, so to begin with, if we look at access to health care, one of the populations which has the greatest disparity would be those people with disability. And the folks that rise to the top are those people with physical disabilities, often who use wheelchairs, whatever, and people with some variation of a communication disorder, okay? And if you look at the data, this is health insurance disparity for those folks as well. Motor disabilities, intellectual disabilities, of course, rise to the top, and people with communication disabilities. So those folks are who I want to talk to you about, okay? Because they're not going to come in and chatty chat with you. If the person's had a stroke, he may, and I want you to remember, communication is two-sided. It's not just what they say to you. They may not have a clue what you're saying to them, okay? It's receptive, meaning what that person understands, versus expressive, what they can say, okay? So don't forget that. It's as important that you change how you interact with them as it is how they're going to be talking to you. So I can show you zillions, and we'll show you some very cool devices for people to use expressively to tell you things. But you got to understand they may not have a clue what you're saying to them because of a cognitive deficit, because of a brain injury, because of aphasia, because of whatever. And so what I thought the easiest thing to do is to take the major disorders that you might run into, so to speak. So that would be stroke, head injury, cognitive, intellectual disability, hearing loss, those kinds of things. And we'll take each over what you need to do receptively so they understand and what you need to do expressively, okay? And the characteristics that those folks might have. And then I want to show you a couple of pieces of technology for each. And remember, for every one piece of technology I show you, there are 10 others, okay? So we established that those folks are at risk for health disparity. We've established that we both are interested in what they can say, but what they can understand of what we say, okay? And the communication is exactly the same as what Dr. Helms was saying. Our ability to get information from patients, our ability to understand, and then their ability to interact with us, okay? So what are the major barriers? What are we looking at? We're looking at people who have speech problems, hearing problems, comprehension of language, and then use of language, okay? The one thing I don't ever want you from this day forward to let your patient walk out without you knowing whether or not that person has a viable communication system. There are no patients who cannot communicate, okay, unless perhaps they're in a coma, whatever. There are no patients that cannot communicate. We can figure out a way. All too often, patients are released after, let's say, head injuries, and I'm sorry, we can't do anymore. And of course, a lot of that has to do with payment. Remember that. I'm not showing progress, and so I can't get payment, and the rehabilitation facility may not be able to keep that person if they don't have the payment, okay? But there are always other ways to go after the patient is out of the rehab setting. And we do this over and over again. Get those kinds of patients. Slow things down a little bit because we may not be under the gun as much as the rehab hospital is. And then look for ways for that patient to communicate. And that holds true for children with multiple and severe disabilities. We work with kids who are deaf-blind, and in conjunction have cerebral palsy and motor disabilities, and I've not met in 42 years only one child that I couldn't get a system in some way for, and that was because she was so fragile that if you stimulated and talked with her, all her levels went off and it was just too dangerous. Okay, so 1 out of 43 years ain't bad. I'm telling you how old I am, but that's okay, because then I get to retire. I can't wait. That's pretty soon. Okay. So back to the main issue. Does my patient have a way to communicate? That's the issue. So who are we talking about? In adults, we're talking about people with who are hard of hearing and have deafness, people with brain injury, TBI, stroke, head, neck cancers, okay, that may not have risen to the top in your brain here, okay? But you take out their larynx, or you take away a good portion of their tongue, and they are not going to be able to communicate clearly, okay? Now remember, these are intact folks, and all of a sudden, just as if I came and ripped out your larynx, which you wouldn't like, it'd be messy, what would you do? Think of the emotional impact, okay? And it used to be, well, we just wrote. Well, you don't have to do that anymore, okay? There's all kinds of simple electronic devices, simple apps you put on your phone, and the minute the person wakes up, they've got text-to-speech, okay? They have a way to communicate with you. That has to be done and is done by the speech-language pathologist before surgery. That's laid out, okay? And if it hasn't been and you're the physician, you need to make sure that that was done. Okay, so adults with head and neck cancers, neural diseases, ALS, MS, progressive. And you have to be able to change what kind of instruments you're giving to this person as, unfortunately, his body deteriorates, okay? Folks with developmental disabilities, you're familiar with that. Second language users, okay? People who don't speak English, this is a problem. You can't just hand them a handout and assume that they understand because it's not written in English. And then, of course, individuals with cognitive impairment. Who are we talking about with children? Again, people with hearing loss or deafness, brain injury, developmental disabilities, much more that you're going to see if you work in peds, so cerebral palsy, Down syndrome, any type of syndrome. Autism. You know the numbers with autism have increased dramatically, whether that's just because the diagnosis has been changed and it's given more often, or if there's actually a change, nobody knows. But anyway, those folks have significant communication problems, and you have to be able to understand. Kids with behavioral problems, second language, neurological, and cognitive impairment. So, number one, there are no aphasics. There are no Down syndromes out there. You know what? They're people. And I'm preaching to the choir here. You already know this, person first language. But people are not confined to wheelchairs. They happen to be a wheelchair user, okay? And a person with Down syndrome is a person with Down syndrome. They're not a Downs, okay? You think you don't still hear this, you hear it all the time, okay? So person first language is the very first thing in terms of communication. And then the terminology around disability, not handicapped, not confined to, not suffering from. We don't suffer from cerebral palsy. We have a young man or woman who happens to have cerebral palsy, okay? All of those remarks give such a negative impact, and so it's no wonder that these folks feel discriminated against, and are, because of the way we're viewing it. They're not sitting there saying, I'm suffering from. We're saying that stuff, the supposedly able-bodied folks. Okay, so how am I going to talk to this person with a disability? And this will go across any disability, really. Obviously, the big thing is to look directly at the individual. If they have a hearing impairment, they have to have the light in back of them, so it's coming on your face, okay? And they can see if they happen to read lips. Now, Remember, if you have an individual using a second language or an individual who is deaf and uses sign language, okay, and he or she has an interpreter with them, you are not talking to the interpreter. Do not look at the interpreter and ask questions. You're talking to the person with deafness, okay? The interpreter will read what they're signing, and they will sign what you're saying. But you need to be looking at the person. And that counts whether he has aphasia or he has Down syndrome or he has whatever, okay? We're looking at the individual. We address people, if they're adults, as adults. My mother, God love her, whew, she was something, scared the hell out of me for 50-something years. So she's 94, okay? She actually died the next day. And two things in the one day. The physician came in and he kept asking me questions. She finally said, hello, I'm here, And then that night, my brother came in and he sat down on the bed and she's saying something and he leans in really close, thinking there's some endearing thing she's going to say. And she says, get the hell off my foot. Totally intact person, okay, even though she's 94. We assume people are not cognitively intact. Now, if they're not, you're going to figure it out pretty quickly. But we want to look at the person directly, talk to that individual. There's nothing wrong with then asking the family, how does this person communicate, if you need to do that? Or ask the person directly and then glance up at the parent or the spouse or whoever, okay? So you're establishing respect and interaction with the individual, but you're saying, in case they can't understand, can you tell me? And if a person has an augmentative system, feel free to go ahead and ask them right away. Okay, oh, I see you're using a device for communication. Can you explain it to me quickly so I understand how it works? Okay, they'll be thrilled that you asked and that you're talking to them. So feel free to do that. Okay, and simple things like, a person who is a wheelchair, who uses a wheelchair, that's an extension of their person. So you're not going to be leaning on that. And, just like if you didn't know me and I came in and just leaned on you and talked with you, you'd think, oh my God, get her freaking away from me, okay? Well, it's the same thing. This is a part of their person, and so we're not leaning on that and that kind of thing. Okay, adults are treated as adults. When you're meeting the person with a visual impairment, okay, you need to let them know where you're sitting, who you are, identify yourself before you do anything else, okay? Because not being able to scan the room, perhaps, are you the doctor? Are you the nurse? Who are you that's talking to me? So identify yourself first, let the person know where you're sitting. And then basically these just kind of summary things. Feel free to offer assistance, but offer assistance before you do it, okay? It's like people with vision impairments and they're going to cross the street and you're being a good Boy Scout, so you latch onto them and start pulling them and they're like, no, man, get off of me, okay? What do you think the dog's for? It's the same kind of thing. We offer assistance, but we don't do it until the person says yes or no, and they may need no assistance, or they may really appreciate the fact that you're offering that to them. Okay, so I'm going to give you some suggestions. We're going to look at a specific disorder. It'll be brief, but there's lots of information about that disorder, the characteristics, and then after we've talked a little bit about that, then I just want to show you little pieces of technology, some of them extremely inexpensive, and you should always have them with you in your practice, okay? And I'll show you some of those. Okay, so we just said that. Okay, so let's take hearing loss, deafness first, okay? Very first thing you have to remember is there is a deaf culture, okay? Not all people with deafness believe that their child who is born deaf should have a cochlear implant, okay? So we bop in there and we go, oh, this is what you're going to do in this surgery. And in that culture, that is not what they do, okay? So first you have to establish the culture of the individual. Do they want a hearing aid? Do they want a cochlear implant? Are they strongly tied with the deaf culture, which uses sign and they do not consider themselves disabled, okay? So that's a really important point to begin with. Now, folks, not so much in the deaf culture, just kind of the person with the hearing loss. My husband, deaf as a doornail, I don't know. He's driving me nuts. He's getting older, and it's hard, and I'm like, oh, God, what am I going to do when he's 5 years older, 10 years older? It's going to be so ugly. Do you want him to come and live at your house? He's a nice guy. Okay, those guys. You have to really look at how you're interacting. So what's going to be challenging for them? Understanding auditory input, of course. Relaying information because they didn't understand what your question was. Okay, so the accuracy. Understanding the directions that you give them. Okay, so if a person has a hearing impairment, obviously you have to augment the directions with print or pictures. Okay, so if your person has, skipping just a bit here, but let's say aphasia, or they have a cognitive impairment, and that story Dr. Helms told this morning, I am going to be haunted by that story for the entire rest of my life. The man with the insulin giving it backwards. Holy crap. Didn't that just, oh my God. But what if we use universal design on our handouts? So the gentleman wouldn't have to say that he couldn't read, because it's incredibly embarrassing to say you can't read and you're an adult. But what if it's just universal design? There's print with directions, and then there's a picture that accompanies each one. And so for the insulin, wouldn't it have been nice if there was a wide arrow that went up and it was red, meaning you're high, and the insulin injection was up there, and then the other end of the arrow was blue or green or whatever cold would be, meaning you're low, and there's a glass of orange juice there, okay? What a simple way to have gotten that information across to the man. He didn't have to say, I can't read. Universal design, you give it to everybody, okay? And therefore, we're not singling out, oh, you can't read, so you get this handout. It's so much easier. Makes your handouts a lot more attractive and interesting, but it gets at what the person needs. Okay, so think universal design with when you're handing out things. But obviously, if the person has an hearing impairment, we're going to have print. Okay, what else? Well, simple mobile devices. Okay, I didn't bring my iPhone on. Everybody in God's earth has an iPhone, okay, or some kind of a phone. Pat has a phone. He's very proud of it. Okay. Free for nothing, or maybe for $1.90 or for 99 cents. There are all kinds of simple apps called text-to-speech, okay? So the person comes in your office, and he prefers not to have the interpreter tell you everything. He wants to tell you the information himself. Well, let me show you this. And so, as I said, for each of these, we'll have a little piece of technology. So here's just an iPhone that has a really simple text-to-speech app. It costs $1.99, I think. They're free ones as well. And you've just asked the person, you're the internist, or you're the PA or the nurse practitioner, and you asked them about allergies. And you hand them a little text-to-speech device so they are totally independent.
I said strawberries.
I said strawberries. I'm allergic to strawberries. Anything else? I'll put that in there for you, okay? So not that we want to bypass the interpreter, but maybe the person doesn't want to have to go through somebody else. How cheap and inexpensive can you get, okay? This is something that should be with you all the time, okay? Every time you see patients, because you don't know what they're going to need. The other way around that is to make sure they understood what you said, so you can type it in and they can read it, okay? So simple text-to-speech apps, absolutely totally necessary, especially for people with hearing loss. And they're also very, very good for people immediately after a laryngectomy, immediately after head neck cancer surgeries. Those are intact folks, okay? But you've just ripped out their communication. Think of the devastation, but we're good. We're good. You can tell me anything you want here, okay? And it needs to be immediate. Not 6 weeks later when something else didn't work. It must be immediate, okay? And so that should be there, and it should be determined long before they ever have the surgery. Okay, so this is something that's available for you. It's little devices. It's a set of information that you would need to know about hearing loss and how you would want to interact with an individual who's deaf or hard of hearing. Let's look at somebody who's had a stroke. Now remember, with the stroke, potentially you have 3 issues. One, the person may have a receptive language deficit, so they don't understand what you're saying to them. Second, it could be primarily an expressive language problem, so they have trouble remembering the words or putting the words together or telling you what, or answering your questions. Very often it's global, so it's both, okay? But then you have the person who's cognitively okay, but they have oral speech problems, okay? And they can have a dysarthria, which is secondary to muscle tone disorder, neurological damage, or an apraxia, also neurological damage, but that has to do with more motor planning, okay? The muscle tone's not that bad, but they can't plan the movement, and so that would be a speech problem. So you could have expressive, receptive, just speech, or global, everything going on, okay? You have to know that, and you have to know that before you start talking with them, okay? So that comes under the column of impact there. What kinds of problems are you going to see? And then what are you going to do? You're going to, again, some of these repeat here. You're going to look at the patient, talk directly to them. Make sure that your language is simple and clear, okay? Not baby talk, not like you're talking to a child, but simple syntax, simple grammar, simple, clear, 3-4 word utterances, okay, so they can understand. Don't rush. A lot of these folks can get it out if you will just wait. And I know you're on a clock, but by God, if you accepted this patient, then you freaking slow down, okay? Okay. Pat says I can say that. But see, I'm going to retire in a few months. It doesn't matter what comes out of my mouth. Okay. So slowing down with your patient and giving them a chance to either remember what they're trying to tell you or remember the exact words. Sometimes they could answer, but they can't pull the word. But very often they could print or type it because of where the damage is. So is there another way you can tell me? Before you ask his wife, ask the person, is there another way you can tell me you can answer this? The patient needs to feel secure and that you respect him, basically, okay? Visual supports, gestures, what we call multimodal communication, universal design, again. So universal interaction, you can use gestures, you can use pictures, you can use slow, clear speech, all of those kinds of things, multimodal input to these folks, okay? Prepared handouts, so you don't have to scroll something down, prepared. Now, this is where we start looking at something called AAC, okay? And we're going to talk about it through the entirety of the rest of the disabilities that we talk about. And AAC is augmentative and alternative communication. Came into practice a good 25, 30 years ago, and we started, with pictures on a cardboard piece of paper, and I'll not deny that we still do that sometimes, but all the way up through $20,000, $30,000, $40,000 instruments that are extremely complex. You don't have to have those, okay? Virtually everything that those do, except for people with like locked-in syndrome where all they have is their eyes, virtually everything else, we can get something immediately and then move on to the technology, which can be expensive, but very often is not, okay? So we'll look at that a lot in a minute, but let me show you a very nice, simple app for folks with aphasia. These are, don't do that. These are absolutely free, okay, free for nothing. They're from Lingraphia, and these are all in your notes. And so I'm going to pull one up. These are simple little AAC apps for in the ICU, for immediately after surgery with laryngeal surgeries. They're for folks who have dysphagia, swallowing disorders. There are ones for just simple conversations with aphasia. The cool thing about them is they're also ones like if your patient or if this person is alone at home, okay, the phone rings. What's he going to do if he can't answer the phone? Now, maybe motorically he could pick up the phone, but if he has aphasia, expressive aphasia, he can't use it. So these are just so nice. And I'm gonna,
Just a minute, I have something to say.
okay, let's look at.
I don't understand.
Terribly, terribly important one. Some of the others in here are, I have aphasia, I can't answer you, but I do understand. And then the next one says, say what you want to say and I'll write it down. Okay, so at least he has access with a free for nothing app when he's at home, because home security is the main thing. It's absolutely necessary. There's not always somebody who can stay with Grandpa, okay? These are very useful when you go to the physician, when you go to therapy. So they're pre-programmed. This is called digital speech, okay? It's taped, and that's one way these work. I'll show you many other ways. Now, there's also, Lean Graphia also has an extensive website with all kinds of free information about stroke, about the technology that's available for people with strokes. You can go in and play with those online to see if they're, but I was going to say see if they're worth it, but they're free. So anything, I mean, that's absolutely worth it. But think about this. This is another thing that should be on your phone 100% of the time, or on the iPad. You go to the orthopedist now, and the poor soul can't look at you because he's got to type everything in here and send it to medical records before he walks out the door. So he's got his iPad in his hand, right? Okay, can switch to another app, and the person can use that if they don't have their own device. Very simple, very easy, very inexpensive. These are kind of fun too. I don't necessarily recommend them, but they have videos where the person can practice saying words and sounds and things like that. That would have to be decided by his specific therapist, but they're free and they're there, and patients like that. Okay, who else do we want to talk about? What about a person with a brain injury, TBI? Okay, here again, we often have a person who's been intact, and now some level or a huge level of their abilities are gone, okay? You think that's not depressing? On top of everything I'm telling you here, add in depression, and then think about these older folks. Oh my God, my mother couldn't hear a damn thing. Do you think she would get a hearing aid? Wait, a little mess up my hair. Oh, geez, she wouldn't get it, okay? But what would have been so very nice, now she was too social to get depressed and way too mean. But many folks who have undiagnosed hearing loss, especially elderly folks, are gradually isolated from other people. You know that. I'm seeing heads because you got your grandma or whoever, okay? Gradually isolated, and the isolation leads to depression. And then people begin to diagnose them with what? What do you decide they have? You know, they have dementia. They don't have any dementia, they can't hear. And then they're depressed, and then they're isolated, okay? So here's a question I want you to ask every single soul you see for the rest of your life. Not at a party, I don't think that'd be appropriate. How well are you hearing? And my mother will tell you that it's fine, and then you behind my mother are shaking your head, going, she can't hear a damn thing. And this is the other little thing that you want with your stuff, okay? You bring your iPad, you bring your iPhone, and this is called a pocket talker, okay? Very inexpensive. You clip this on here, just like the mic, and if the person's willing, you have them put these on, and it's very, very inexpensive. It amplifies what you're saying. You know at least that they heard it, just in case you didn't hear me, okay? And then it might be really a wonderful thing to be hearing, and you may be able to convince them that perhaps a hearing aid would work. But this needs to be with you 100% when you're treating. The iPhone needs to be with you. The iPad needs to be with you with the simple, inexpensive apps, okay? Okay, so what we're looking at again, now when we're talking about TBI, we're looking at more because you could have receptive problems, understanding, you could have expressive, you can have dysarthria and apraxia with speech. But you can have relatively little of that and have more executive function problems, okay? So your memory, your ability to attend, your ability to problem solve, your ability to sequence. And now you're the PA, and you say, well, do this and blah, 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 and 4 times a day and blah, 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 blah. There you go. And here's your handout. Well, they may have lost their ability to read as well. You have to remember that, okay? So what's out there for these folks? I'm going to skip up just a little bit. It's their handy dandy iPhone again. You can put in their schedules. You can put in maps to help them get where they're going. You can put in planners. You can put in memory assist. You can use the alarms. You set the alarm for every 4 hours when he's supposed to take his meds, okay? All of those simple, there's no cost because they're already on the tablet, they're already on the iPhone, they're already on some mobile device that they've got, okay? But you have to use those with the individual to support them. Take pictures. The man with the insulin, if we had just had the picture in red when it's high, and the next photograph shows him checking, and the next photograph shows him the insulin bottle and his injection or however, whatever he uses, and the next one, you feel better, okay? Now, he simply was illiterate, but our folks with memory problems, with organizational problems, executive function, if you will, that covers all of that after brain injury, works just as well, okay? He's using a device that everybody uses. It's really simple, and it walks him right through it, and it's not embarrassing because he doesn't necessarily, of course somebody's going to check and make sure he's done it right, but it's not necessarily that I have to get my wife or my sister or someone to come and monitor me all the time, okay? Maps. Maps are the best thing in the world. The woman comes on there and says, turn left, and then if you don't, she goes, reroute, rerouting, you're screwing up here, okay? They're talking to you. They talk you literally through it, okay? There is so much more technology now for folks with brain injury and executive function problems that we should be able to really help them. I'm going to go back, and then the next group of people I'll put in here, and then we'll jump ahead, would be people with intellectual disabilities that may be related to any kind of developmental disability, okay? And so you will see that the potential solutions are going to be very similar, looking at the person, asking the family how the person communicates. Ask the person first, then ask the family. Keep the language clear and simple. Don't rush the patient. Use age-appropriate language. My sister had Down syndrome. She's 58 years old. You know, and some nurse is talking to her like she's 2, and she's like rolling her eyes, you know. No. If she can't understand, it'll be obvious. Then you can drop down. But don't be starting talking to my sister. Remember, she's my mother's daughter, as if she's 2 years old, okay? So age-appropriate language, visual supports, repetitions, and one thing with all your patients, teach, reteach. So you give them the simple directions with the supportive handout, whatever they use, and then you ask them to tell you back what they're going to do, okay? That singular element, the research shows, appears to be one of the most efficient to increase patient compliance, okay? Teach, reteach. Just take a second, ask them to tell you back. Okay, so on all these things I've talked about, I've referenced the idea of augmentative communication. So here's an example of a young man. He works for us. I've known him since he was 9 months old. He has cerebral palsy. He did not become an oral speaker, but he went all through regular ed. He's had a year of college. And one of the things he does, he works on one of our grants, one of the things he does is demo systems, and we take videos, okay? So here's one. He's just going to demo for you a very simple text-to-speech in which in one he types the answers and gets the voice, and in the other he's preloaded some responses. Now you may be familiar with this, and if you are, I apologize, but then we'll move through a lot of different ones that he's done for us. So these are AAC instruments.
Nick, what college do you attend?
Western Kentucky.
That's preloaded.
How many classes are you enrolled in?
3.
What is your favorite class?
Math.
Why do you like it?
It is fun.
Okay, now, Nick actually lectures for us. He preloads and then he answers questions using text-to-speech. So preloaded stuff, of course, is going to be much, much faster. Text-to-speech is slow, but in Nick's case, and there are other ways that you can use picture systems that link together, and he says, nope, those are for children, I will not use them. So your system's going to be designed the way the individual wants it designed. Okay, so who else uses AAC? Really anyone who doesn't have oral speech output. I don't care the age, I don't care the disability. We can come up with a system which will work for them. It doesn't have to be electronic. Electronic is faster, but if they can't do that, we can mirror virtually anything. So what are some of the decisions? And you just need to know these. Now, you're not going to go design the system because an SLP and assistive technology person will do that. But if you're looking at them and they don't have a system, you need to know what they ought to have, basically some way to communicate, and your recommendation really should include a referral for AAC. If they can't communicate with you, they need a referral, regardless of your discipline. Okay, so we can have no tech, which is simple pictures. We can have low electronic, which is just battery devices that you hit the button and it says something. Or you can have high tech. Nick was showing you high tech with an iPad. There are instruments just for text-to-speech, and there are instruments that can be done with interacting just with your eyes, all those kinds of things, okay? So those would be no tech, I can just make them. These are little devices that are relatively inexpensive. Now remember, as soon as you say it's for a disability, the cost zillionizes. It's ludicrous. And that's why we go with apps as much as possible, because they're so much more affordable. But there are patients where that's just not appropriate. It's going to have to be much more complex technology, and it costs more money. And these are all different kinds of electronic devices. Basically, many of them are small computers, okay? And you can have voice output, and the voice is either digital, it's already in there, it's taped, or it's synthesized, okay? And that's what text-to-speech is. That's what anything where the person generates himself and puts things together, and then it's read back, is synthesized speech, okay? Now, what's really cool, and in the interest of time, I'm going to say this right here. Individuals with MS and ALS, and you know that's a progressive loss, okay? And they're eventually going to be, first they lose their volume because of the respiratory system, okay? And then as things progress, they lose some of the oral motor and become less and less intelligible, okay? So then you hand them to a device that sounds like a robot. It's not cool, okay? So what people have done, and it's such incredible technology, there's two ways to do this. It's called voice banking. If the person's going to have a device that'll be digitized voice, basically taped, you just have them tape everything under the sun while they're still very fluent, and you can load any of that into a device, okay? The super cool is another form of voice banking, which I would love to get my friend Nick to do. You take a lot of samples of the person's voice, whether or not it's all he's got left or when he has a good voice. They take that, and with incredible technology, they define all the elements of the voice, and they develop a synthesized voice that sounds like that individual, okay? And you can do that even for someone who like Nick, who really only has like, that kind of stuff, or you can take it with an ALS patient before things progress too much. And of course, those are a little easier to do. But voice banking is totally revolutionary and so amazing. Okay, so basically the things you're looking at is, how's the person going to access the device? Is he going to touch it, or does he have to scan? I'll show you scanning. What kind of representations are you going to use? Is it print, or does he need pictures or something else? Is it going to be static, which there's the same set of pictures that stay there, or dynamic, which is so cool. You only have to put a limited number of pictures on the home screen. So if I want to say eat, I touch eat, and then all the possibilities come up. It's a dynamic screen, and it can change and change and change depending upon how you program it, okay? How is it organized? Usually in a grid. And then you can have voice output. It's typically optimal, except some kids, there are a few kids with autism that just really the sound is just more than they can stand. And so you might want to just stay with visual, okay? And I'm not going to, we'll skip through those in the interest of time. But here, this is, I said you could use direct selection, where you either look at it or you touch it, or there could be scanning. So Nick is demonstrating scanning here.
Did you see the game?
Yeah, the UK game, I saw that.
I love the UK.
I love UK too.
Did you like the game?
Yeah, it was a pretty exciting game, but what did you think about the refs?
The referees were bad.
Okay. Now, he usually enters something negative about the University of Louisville because our family are rabid fans, and so he really enjoys that, but I made him take it off this one. Okay, so that's visual scanning. Now you can do auditory scanning as well. You see here, there's no big instrument in front of him, okay? There's that little tiny blue box, and so he starts to scan with the larger switch, and then it whispers his options. So this would be for an individual with visual impairment, okay, that you still want to have a system. Oh, I'm sorry. I'll do that one real quick because it's interesting.
Nothing much, Nick. What did you do last night?
Now he's just listening to it. You can put a little earplug so nobody hears it if you want. Comes to the one he wants, and then he answers the question, okay? So there's auditory and visual scanning. You can get as complex as you want. This little boy is 4 years old and could use a board with 34 entries, which that's lovely, but how many more can you get? And so I won't run him, but then he went to a dynamic screen, which has a home screen, which he can link then to produce sentences and all kinds of things. Again, with people with visual impairments, and this is more for kids who are very, very, very significantly involved. We work with lots of kids with hearing and vision impairments, both cerebral palsy, motor, and then sometimes, and although typically, an intellectual deficit as well. And so these instruments are backlighted, okay, if they see light at all, so they can focus, and then they're tactile tactile representation is the only word I can come up with. So, you know, eat would be a spoon, you can see there. IW is I want. Okay, so he can form sentences and scan across. The technology for those folks is getting better and better. Please know about cortical visual impairment, okay? The kids whose eyes appear intact, but they're not interpreting what they're seeing. It's incredibly important, very confusing, and those kids can be difficult to work with, okay? But you need to know about that. Certainly if you're in peds, you've got to know about that, because we see those kids after head injury, we see them if they have lost oxygen at birth, We see them in all kinds of situations. This is just a cute little thing that we start kids off with sometimes, where you don't care what they hit as long as they hit something. So anything that she hits,
I like wearing those.
it's going to say something, okay? So she learns that I can communicate that way. So here are some really, really, really cheap ones that you can just get. You just download offline, and we'll just run a couple of those that you can see, because they're not terrible. You'll want more complex ones, and you'll want ones designed specifically for your patient, but you can start them off immediately, and that's what's important. Oh, it's upside down. Oh, how unfortunate. Well, if you could see that, they hit the car, and it said, let's go. And then they have the image of home. And then they might hit eat, and it'll come up with a whole number of things. It's inexpensive, and it's immediate. There's a whole lot of those. This is just another example. I have these all listed out with their characteristics on a handout if you're interested, and Pat has access to all those. Okay, the big thing, a big thing I want to get across is that all individuals communicate. This young man is a child in middle school that we worked with, significant cognitive impairment, severe motor impairment, vision impairment. I believe he was blind. He might have had cortical vision impairment, but I think he was blind, and then also had a mild hearing impairment. And yet, can we get him past just, oh, well, when he cries, he means this, and when he grunts, he means this? Give me a break, you know? We underestimate these folks constantly, and so they never go forward. Our data shows that of the kids who have the most severe disabilities in this country, we have data on 60, 70, 80,000 kids. Of those kids, and these are just with the most severe disabilities, 70% can use verbal language. That's great. The remaining 30% who don't have verbal language, unfortunately, there's an assumption that they can't communicate. Less than half of these kids have augmentative systems, which is ludicrous because we can fit them to anybody. And in our research is showing in the programs we have used in Kentucky that we have dropped that from of the kids that we've worked with, 90% of the kids we've moved on to a system. 90%. That's ridiculous. The national average is 48. You know, it isn't difficult, our research. You know, I wish I could say I was a brain surgeon, but I'm not. I'm a speech pathologist, and we can do this. So this is just a great little guy.
Let's check to see what we're doing today. What do we do next? What do we do next? Hit the button and show us what we're doing next. The button down here on the left. Right here. Hit that button. Look at that big old smile. What is this?
It's good when you turn it on.
Hit the button.
Okay, yesterday was.
Exercise. All right. Let's do it.
So he's very, very happy that he's going to do exercises. Okay. He went on. This blew my mind. He went on to, they were reading him stories, and they'd ask him questions, and they gave him this little 4-choice device. Okay, it sat unstably on his knee. And they didn't even put tactile symbols on it. The kid is blind. And he had learned the position of the responses. He was answering those responses, okay? Without that, we would assume that he's in a profound range of mental or intellectual disability, and he is not, okay? He was understanding, though, but it wasn't a way to get it out. And this is the example. This is Nick does lectures, and this happens to be one of his that he uses his AAC for. Okay, so how are these things funded? Obviously through Medicare and Medicaid, vocational rehabilitation, and the schools are supposed to be offering this. Okay, and that's all I'm going to tell you is they're supposed to be. Okay. Okay, so back to the basics. So then if we look at progressive neurological diseases, we have mentioned that AAC is very important, and the technology that's super important is the voice banking. This is really interesting. I'm going to do it very quickly. Some folks, the only output they have is vision and gaze. So locked in, you might have locked in syndromes or the end stages of ALS or MS. And so this is just an example Nick's showing you of how these systems are calibrated with just your vision, okay? And then he'll answer a question. It's a very quick little tape. So he's following that and he's clicking it as you see and blinks. So they're calibrating where his eyes go and how much control he has. Now he has fairly decent control of his eyes, really more than anything that he's got. And then once that calibration is done, they can set up things. So she's asked him, what's your favorite movie? And he's going to answer just with his eyes, okay?
So when I build these boards, I don't completely rely on the text feature. So what we have them do is start a journal of the things that they enjoy, shows they like to watch. And I always do a safety page. The safety page is because a lot of people rely on the fact, and they rest in this peace of mind, that their patient is going to be attended to at all times, forgetting that the person attending to them is not immortal. So the idea is that whoever's going to be with him, if something happened to them, he could still activate a safety response. And what I love about this device is you can link it to your phone, call 911 through the device, and then have a board where you say, like, my address is I can't talk, you need to send help, my mom is hurt, or, you know, in that way.
Okay, so that's a speech pathologist just letting you know safety issues are, and did you hear Nick? Because he's very much in that situation when she was saying, what if your mom isn't there, whatever. He's saying, yeah, man, this is really important. Now, that bugger, he's got all these problems. One night he texts me from his phone. I'm like, you didn't tell me you had that much fine motor control. What are you doing? He's just laughing. I had no idea. He was texting. Okay, so again, I'm the person who's supposed to be, never underestimating. Yeah, I underestimated Nick. The kids using texting. Okay, we talked about voice banking. Head and neck cancer, we mentioned that. You want immediate communication, but some of the other technology you need to know about, and if you work in this field, you do. After the larynx is removed, what we used was an electrolarynx that had a buzz. And if you put that in here, it's essentially a voice that you can articulate over. And it's okay, but I mean, the person doesn't feel great about it. Well, now, sometimes immediately after surgery or sometimes maybe 6 weeks later, whenever it's safe to fit the person for a TEP, that's tracheoesophageal voice prosthesis, okay? That goes over where the trach is, and the air is forced up, and there are no vocal cords, you're not vibrating that. You're actually vibrating some of the pharyngeal tissue. It provides a voice. And so then the person doesn't have to rely on some external device, okay? So that's a TEP. Now, not to be confused with speaking valves like a Passimura valve, which you'll see on little bitty kids, as well as adults, okay? And that's when the person has a trach. Now, if you put a trach in, the air's not going to be going up through the vocal cords, right? So there's no vibratory, even though the cords are there. So the speaking valves, essentially, it's a one-way valve. The air goes in, and then it's forced up through the cords and provides a voice, okay? And so then the person has voice. I remember see that baby there. I remember the first time I did it with a little kid, and I talked to these folks that did this all the time with adults, and they said, now there's one thing to remember. Do not, when you put it on the first time, do not sit in front of the kid. Because, when you cough out a trach, you cough out everything under God's sun, right? You ever done that? So I put it in, and I'm all nervous, and I put it on, and she coughs, and I'm sitting smack in front of her. Like, oh, this is why they told me not, as I'm covered in God knows what, this is why they told me not to sit in front of her. But the really cool thing is, if the person's on a vent, you are fine. The Passimura valve's not going to be up here because that's where they're breathing, where it's going in. You just go farther down the line, put the valve in, and you still get the voice, okay? So virtually, if I leave you with nothing else, virtually everyone communicates. We can figure out a way for virtually everybody. If you are doing training, I've included here some stuff that came from human development a few years ago. It's been used all over the country in med schools and in PA programs, and it's specifically designed to teach people to talk or to interact and communicate and do interviews and stuff with people with disabilities. And I'll show you just this tiny, tiny speck of this one with a person using an augmentative device. Well, maybe I won't. Poop. Okay. That didn't work. Anyway, that is still available. I can get you the website for it. And even if you just use a piece of it in your training programs with nurses, physicians, dentists, there's a whole one for dentists that they're excellent, beautifully done, where it's real patients, real physicians, real PAs, real dentists, talking to people with augmentative devices. Okay, so basically then, I gave you, there are handouts available for AAC, all the materials I referenced, whole sets of apps for all of those different disabilities that are very, very inexpensive, and then sites for the more expensive technology for folks with disabilities. And so I ask you, please don't let anybody leave your office or your therapy room again who doesn't have some way to communicate. And please don't believe when you see a report that they do not communicate. People communicate in some way all the time. That's all I know.